food addiction counselor here in Toronto. Today's topic, how to target emotional eating and cravings. Now, allow me to introduce Dr. Arya Sharma. He's the professor of medicine at the University of Alberta and scientific director of Obesity Canada.
Well, thank you, Sandra, for the introduction, and welcome to everybody. So just a quick reminder that Obesity Canada is Canada's national registered charity dedicated to improving the lives of Canadians through obesity research, education, and advocacy. Through the work that Obesity Canada does, we educate health professionals, we support researchers, we mentor trainees and students, and we work very closely with policymakers to ensure that all Canadians living with obesity have access to the same prevention and care measures and efforts as Canadians living with any other chronic disease. Today, which is going to be the last one in this quick series that we've had over the past couple of weeks, I'd like to welcome two of our most, I would say, most prominent obesity experts in the country. I'd like to start with you, Ali. I mean, you've made a big name for yourself recently, not just as a doctor who sees a lot of patients with obesity, and you've been doing this for a long time, but you've also been very, very vocal as a patient advocate, and you've talked about weight bias and discrimination, all of those things. So why don't you just give us a very quick rundown to your own background, your interest, and maybe tell us a little bit about, the kind of things that you're really interested in right now.
I'm Ali Zettner. My background's internal medicine. I have been in practice in obesity medicine for 20 years. I practice here in Vancouver. I myself have been really passionate specifically about advocating for patients and combating weight bias, period, in medicine, whether we're talking about treating obesity or just treating patients, period, and started an organization through Obesity Canada called No Fat Shame. Our goal is not just advocacy, but we do a lot of work in medical schools and in residency programs teaching our future doctors of tomorrow about obesity and about weight bias.
Well, thank you, Ali. And over to you, Michael. So Michael Valles, he's I guess now Professor Emeritus, over in Halifax. He's probably one of the most prominent behavioral psychologists in the country, and certainly one of the most prominent persons globally who's working in the behavioral psychology of obesity. So Michael, welcome. And tell us a little bit about yourself and maybe what brought you into obesity, because I know that there's a lot of psychologists, practicing psychologists who maybe don't have the training in obesity or maybe don't have a strong interest in obesity. So what took you there and what is it that you're doing now?
Well, thank you very much. So yeah, I have a long history in obesity. My interest really developed when I was in graduate school. And one of the tasks that I was faced with as a resident learner at the University Hospital in London, Ontario, was people seeking jaw wiring for weight loss. And wow. Then the surgeons wanted psychological consultation around this very extreme behavior. And it really exposed me to all of the challenges that individuals living with obesity face. And especially the thing that impressed me most was, and excuse my language, but just how desperate people were, that they were really seeking, and they would consider any form of treatment in the hopes that it would provide a solution to them. So this became a very central point of my work as a health psychologist. And I'm really glad, Arya, that you've raised the issue that psychologists are good at counseling and they can support behavior change. But we do need to make sure that the psychological components specific to the experience of living with obesity are the competencies that are developed. So I spend a lot of my time now really working in the interface between the patient and the provider. So I very much believe, very consistent with Ali's comments around bias and the need to really reframe that. The question is that once you've sort of overcome your bias, then how are you actually going to empower an individual to sustain health behaviors in the face of all the barriers that they encounter? And that's where behavior change counseling comes in. And that's where I spend most of my time in trying to help people develop pathways to success in obesity management. Thanks.
Well, thanks, Michael, for that. And Ali, I want to jump straight into this and, giving your background as a sort of the internist here on the panel. Can you just take us quickly through the what we understand about the actual physiology or the biology of cravings and wanting foods that taste good. What's the biology there? And perhaps as you explain the biology, I also want to ask the question: is that something that only people who have obesity have to deal with, or isn't that something that we all have to deal with?
So just, the quick and dirty is to think of it, if we're a species that evolved for famine, and if our entire survival depends on our ability not to starve, we evolved sort of two systems in our body. It's a bit more complicated than this, but we have a hunter and we have a storer. And if you think about it, anytime your energy sort of acquisition is threatened, you're going to hunt for food and you're going to store it. And so our storage system is sort of in the part of our brain called our hypothalamus. We will leave that, but know that essentially energy regulation in the hypothalamus is as down to the wire as volume regulation, blood pressure, heart rate, body temperature, all of that. Those are all sort of like a hormonal thermostat, if you will. But our hunter system is like our craving center, essentially, and that's primarily through a system in your brain called your mesolimbic system, sort of the compulsion reward. And I liken it to, if you think about it, if we're all sitting in caves 50,000 years ago, somebody's got to leave this cave and go hunt down a buffalo. I don't know about you, but I'm gonna look around the cave and figure out who I can outlast. And I'm gonna sit here and then I'm gonna eat you. That is not a good sort of prediction for survival of a species. So we evolved this highly sophisticated compulsion reward center around food called our mesolimbic system that is hardwired not only to compulsion reward, but into goals, planning, our executive functioning, because as a species, you had to remember where the compulsion reward paid off most. You also have this system that not only responds specifically to compulsion reward, it responds to food cues, so visual cues, and also to even specific functioning. So it's a dopamine pathway, the mesolimbic system, with a variety of different receptors, opioid, etc. And one of the most prominent over-the-counter substances to increase dopamine in the brain, as we know, is sugar. And so not only does it respond to food cues, but it responds to certain chemical substances in foods more than others. So now you have this hardwired, sort of think of it like a high-speed cable internet wire through your brain that's a craving center, that compulsion, reward, pleasure, and planning are its sort of stops along the brain. And it's hardwired to respond to dopaminergic agents like sugar, for example, or carbohydrates. And it's also receives its input from visual cues. Now that's fine 50,000 years ago, but nowadays we live in a world where you're exposed to 600 food cues a day. So yet it's sort of like being hyper acute to sound and living right beside the subwoofer at a rock concert all the time.
Yeah, and I love that analogy, because that's exactly how I feel sometimes, right? And that's what I hear a lot from my patients. So you've talked about the sort of the biology of cravings. Now I want to get to the psychology of cravings, and that's where we have the psychologist, Michael. So over to you, Michael. What is it about, Ali has explained that there's a reward system, so we go out seeking these foods because they make us feel better. But what is it, how do you explain that people who are exposed to, let's say, stressful situations or anxiety or even, trauma, or have had past history of having those adverse childhood events, why would they experience, cravings for foods in general? What's the psychology behind that?
Yeah, that's a great question. And so from a behavioral point of view, we're all really interested in promoting health behaviors. I'd like to make it extremely clear in this context. Eating behavior is not like any other behavior. So don't put eating behavior into a bucket of health behaviors. Eating behavior deserves its own bucket for the neurophysiological reasons just described. And so we have in this sort of limbic system of the brain, the sort of emotional regions of the brain, you have really two primary pathways. You have wanting and liking. Wanting is the go-getter, is the drive to eat, the stimulus to go find food. And this is incredibly sensitive to what we call associative learning. Pavlov's dog and the bell. So any of the pairings that happen work through this dopamine system to really make us prime to learn. So situations that would be associated with food or comfort will elicit the drive, the wanting. And then we have also the liking. When you put the food in your mouth, you'll get a response to that that's really more based on serotonin. And this is where we get reward learning. So the brain is incredibly sensitized through this mechanism that Ali described for us to develop these associative cues. And then where the power of food, so sugar and cocaine have exactly the same effect in stimulating the pleasure centers of the brain. So it's a very powerful substance. It then becomes very easily used from a reward point of view. You're having a stressful day. So many people think about being a stress eater, and they think that the stress causes the eating. We actually don't believe that it's so much the stress that causes the eating, because then if you're stressed at 10 o'clock in the morning, when you've had a difficult meeting with your boss, you'd go eat at 10:01. But in fact, you don't eat at 10:01, you eat at 6:01 or 8:02 or 10:05 later on. And we believe what happens is that then that stress, you kind of use the food as the reward at the end of the day. So it's very much of a reward learning. And this is where the emotional issues, stress issues, or trauma-related issues would affect the way that those systems would dominate. The only other thing to add to the sort of physiology is your executive functions, your frontal lobe, the last part of your brain to develop, which is where you have really the most conscious control. So this is where you can negotiate with people around what are your thoughts on this, what are your beliefs, what we call permission thoughts or restraint thoughts. I've had a hard day, I deserve this. And so we can sort of manipulate basically the executive system, the dopamine system, and the serotonergic system. These actually lead to behavioral treatments, cognitive behavior therapy, stimulus control therapies, reward-based learning therapies.
So Ali, over to you. We've just talked now about the frontal sort of cortex. And you also notice that the fact that we live in this environment where we are constantly surrounded by food, is we are getting all these food cues. Why is it so hard for the cognitive part of the brain to take control and actually remind us, no, we should not be eating that, or we should be making better choices? Why is that so difficult? And why is it that we see this link, for example, or the challenges that people who, for example, have attention deficit disorder, that, we've got mindless eating, what actually happens there? Why is it so difficult for the cognitive part of the brain to take control of the mesolimbic system and maybe the hypothalamus?
I think two things. So first of all, it's not hard for everybody, right? So we're all a little bit different on the inside, just like we are on the outside, right? And if we think about that mesolimbic pathway that we're all referring to, it's like, we call it that line. So it's, compulsion, reward, pleasure, planning, which Michael talked about executive functioning and such. And so you can start to think about it like a bottom-up system or a top-down. So bottom-up means compulsion takes over and executive functioning is last, in terms of if it's almost like a highway. And top-down is that, where Michael works with patients, I nod if you agree, where you sort of use your executive functioning and your planning and what you've integrated from society and try and work as a top-down. So cognitive functioning sort of helps to manage, if you will, the compulsion reward pathways. Some of us have better top-down functioning where we're able to do that. And one of the goals, of course, of cognitive behavioral therapy is to boost that top-down system. And then there are indeed, as you referenced, dysfunctions or dysregulations in that pathway completely. So things like binge eating disorder, or patients who have significant ADD, it's all centered within that mesolimbic system, which we know is linked to a number of different psychopathologies. Addictions are put in that category. And I guess, you know, to answer your point, the idea here is that part of our challenge is some of us just don't have the innate physiology to do that top down, number one. And more significantly, the system itself and the environment that we live in, you know, we talk about choice a lot, and I chuckle because, you know, when we talk environment, everything about the environment, I mean, even this is even more dysregulated, but everything about, when we talk environment, we don't just mean, you know, sugar and food groups and amounts, but we mean, you know, this group of people, we're a species that evolved for famine. We evolved to live in caves. We evolved to sleep, you know, 4 hours spurts. You know, we evolved for very harsh conditions. Everything about our environment is completely artificial. And that pokes that mesolimbic bear 24/7.
Well, thanks, Ali. So, you know, I like how you put it. And one of the things that I'd learned was that, you know, willpower, which of course is what we then have to use, is a very limited resource. And that, you know, at sometimes you just run out of willpower, you might not have enough. And so sometimes you do well, but then sometimes you lose control. I wanted to ask you, Michael, because you talked about, you know, the Pavlov, you know, story of how this is sometimes a reflex. So how much of eating behavior would you say is a reflex, and by reflex, maybe another term for reflex is a habit. It's just something that you do. It's things that you've associated with each other. You know, when I do this, then I automatically think of this, and so I pair these activities. You know, I would call that a habit, versus using food as a coping strategy, where because of whatever is going on in my life, I turn to food as a coping strategy. It's not a habit. It's not something I learned. It's not something I've been doing ever since I was a little kid, but it's something that I, you know, then find out that somehow it's helping me cope. Do you differentiate between the two, and how important is it to make that distinction?
Yeah, I think it's a great question. And I think the important thing to recognize here is that we're actually talking about normal functioning. So let's be really, really clear. We're not talking about pathologies here. We're talking about the fact that the way the human brain works is that, and this is really the choice of life, right? What do you know you should do, and what do you want to do? Now, good luck. You will go through your entire life experiencing the tension between what you know is in your best interest and what you feel like doing. And this will show up all the time because these systems are in constant tension. And so I think it's really important for us to recognize that the emotional system is really the dominant system. And we believe the frontal lobes, by the way, are not even fully developed in girls until the ages of 23 to 25. They're not fully developed in boys until the ages of 27 to 29. So, you know, we have this ubiquitous struggle. It's really important to understand that this drive is normal. We talk about emotional eating, but hold on, isn't virtually all eating emotional? If I like you, I'll feed you. If it's a special event, we'll attach food to it. You're about to come to Christmas. If you're able to host a party at Christmas, don't serve any food. Have a Christmas party with no food. I guarantee you, nobody will ever come back to your house. So this is actually a really important, that eating is actually a normal part of life. And so I think what we need to do is understand, how do we help people really embrace that? And cultures that do well with regard to weight and their relationship to food, these cultures that are you know, more the connoisseur, they have little bits and enjoy it. They eat long time spent in meals. They're not associated. They love food. You try to go to Italy and talk about meal replacements in Italy. I had this conversation with Italian physicians about using meal replacements, and they laughed and they said, no Italian would ever consider using a meal replacement as opposed to eating real food. And so I think we have to recognize that. And then the function of food then becomes, and so this is really where the counseling piece comes in. And so what I like to do is I like to ask people a question, everyone, regardless of your weight. What is your relationship with food? So that you can just try to understand where your cravings, where your drive to eat, the role that food serves in your life. And then I'd like to say, like all relationships. And so have you ever been in a relationship where you loved somebody and they did not love you back? Now just think about that for a second. If you're in a relationship with someone that you love, but they do not love you back, how does that relationship work out? And we know how this relationship works out. So I say, in your relationship with food, you should eat food that you like, but it should like you back. And so now all of a sudden we say, okay, when I eat, I want to eat it. Then when I eat it, how do I feel afterwards? Maybe I need to find a relationship where me and food sort of work in synchrony. And this is where values and goals, and we use the sort of cognitive behavioral acceptance types of interventions, which provide us a whole host of clinical intervention tools that will work with Pavlov, work with Skinner. This is, you know, the rat in the mazes. So that'll help us with our associative learning. That will help us with our reward learning. We use cognitive behavioral therapies to strengthen the frontal lobes, and we help people find values, right? So the average person will say, okay, here I am faced with apple and apple pie. How do I choose over that? And the question isn't apple versus apple pie, because over time apple pie will win. The question is, what's important enough in your life to not have apple pie for? And now if you can start lining up your values, then we start looking at things like, how much pain does a parent suffer willingly to raise their children? How much distress do you suffer to be successful in your career? And if you said to a medical student, you know, medical school should be enjoyable every single moment of the way, of course it isn't, but it's worth it. And so you tolerate medical school because you have the value of wanting to contribute to society. You contribute, you parent where you're giving. The purpose of parenting is giving, and you enjoy every moment of it, even though it's very painful. So this is where we actually find the ability to use these strategies to respect where individuals are. And I like Ali's comment about, just like we're not all alike on the outside, we're not all alike on the inside. So what we can do then is really help people become comfortable in their own skin. So that's both physical, body acceptance, as well as emotional self-esteem.
Right. So Michael, so you've already talked about some of the approaches that you would use, or, you know, by starting to ask that question, and then you've talked about, you know, cognitive behavioral therapy and how you change the thinking and acceptance and all of those factors. But Ali, we know that despite the best behavioral counseling, sometimes it's simply not enough. Sometimes the biology is stronger. And so I want to just ask you the question, what is our ability to change the biology? And what I'm thinking about is, I'm thinking about medication, I'm thinking about surgery, because we know that both of those approaches are, you know, tend to have better long-term success than trying to rely on willpower. How good are we at blocking the biological signals that underline the pathways that you've described before?
And I think, just as an aside, I think let's not, I mean, maybe I'm over speaking out of turn here, but I don't want us to leave here thinking obesity is a behavior, because I think that in itself has been, you know, really sort of twisted in our society. And we also, you know, as Michael alluded to, in North America have this weird binary, almost holier than thou moralistic culture around food. I mean, let's be clear, bad food in Europe is a stale croissant. So, you know, we have this weird good and bad kind of thing, and it's hugely culturally sort of almost puritanical in nature in North America. You know, I joke that Christmas party you alluded to would be a meeting, right? So, you know, a party without cake is just a meeting, quite frankly. And so I think that's key to remind ourselves as we talk about this, that for all of these behaviors, there's huge physiological sort of firings that are happening all the time, integrating our environment into our physiology. So just as an aside, sure. As far as the question as how good are we at manipulating physiology, we're okay, but we're not as good as we are, let's say, in other areas. So, you know, for example, in hypertension, 7 different classes of medications, a variety of different systems. Let's be clear, when we talk about pharmacotherapy, the challenge is that the science has not yet caught up, because we're still stuck we're just sort of learning this feedback mechanism of, 37 different hormones all talking to each other. And if you think about it, we only talked about the brain's involvement in cravings, but it regularly receives feedback from our gut and from our storage, our fat tissue, muscle tissue, liver tissue. So we do have, right now in Canada, 2 different specific medications, both of which work somewhat on our hunter and our storer, so to speak. And so from the craving perspective, we're really talking about how do we sort of help the hunter settle down. In other words, it's not constantly screaming, so that it's even more susceptible to that, top-down behavioral treatment. There is, for example, one medication some of you are aware of called Contrave, Wellbutrin with naltrexone. Together, it literally sort of boosts dopaminergic function, so it affects the mesolimbic system that way, and it has opioid blockers, which also sort of affect the mesolimbic system in that regard. So that's part of its mechanism of action in terms of the hunter. And then remember, all along that mesolimbic pathway, in our compulsion center, in our reward center, in our pleasure center, we have receptors to a variety of different hormones, gut hormones, storage hormones from fat tissue, etc. So there is another medication called liraglutide, a different medication called semaglutide used in people with diabetes in Canada, which is an analog of a gut fullness hormone that literally in some patients can help a bit with that suppression of that sort of craving hunter drive.
Okay,
One last thing, surgery itself, because you physically alter the anatomy of the gut, you alter its communication system to the brain. And we do know that what that tends to do is through that sort of gut hormonal re-regulation, you then transmit to the brain, oh, guess what? You don't have to hunt and you don't have to store because you're eating all the time, because their fullness hormones are through the roof. So there's that piece to it. Can I add one point to the idea of stress eating? And just say that, remember, stress 100,000 years ago was starvation. So your body perceives the stress of a bad day at work or a lost job or a pandemic or a mother-in-law or all of that similar to a primitive stress of starvation. And that physiologically in and of itself can activate your hunter-storer response.
That's a great point. So Michael, I want to finish this off because before we open the floor to questions. And I want to take this down to the topic that I know that normally, Ali is very passionate about, and that is weight bias and discrimination. But I want to talk to you very specifically about the notion of why do we discriminate, or why is there a bias against people using medication or having surgery to control their obesity once everything else, hasn't really worked out. Or in some cases, you would say, in addition to anything else that they're doing. Why is it that so many patients and the general public is resistant to the idea that we should be treating obesity like every other chronic disease? I mean, there's no, when somebody's taking the insulin for the diabetes, they're not ashamed of taking insulin. In fact, they'll tell everybody, right, oh, I'm on insulin, right? Or somebody taking medication for their heart disease was going to tell everybody, yeah, I take medication for my heart disease. I do that every day. There's no shame. There's no stigma. Why is it in obesity that when people reach out for professional help and then, get prescribed a medication or, decide to have bariatric surgery, they don't even tell anybody because there's so much stigma attached? Why is that the case, and how do you counsel people to respond to that?
So let me answer those questions in reverse order. The difference between diabetes and obesity is the lack, until recently, of the diagnosis. And so when you have a diagnosis that you could accept that this is a chronic disease, then all of a sudden everyone shifts. why is that person parking in that disabled spot? They look perfectly fine. And then you see, oh, they've got a cane. Oh, I see, they're visually impaired. Oh, okay, all right, sorry. I shouldn't be upset at you. I misunderstood. It was the wrong category. We kind of categorize in our mind. So I think that's really the critically important thing about placing obesity as a chronic medical condition. So then that shifts. But to speak to your original point, why is this happening? And it's because that sort of narrative of eat less, move more, somehow that weight is under behavioral control, which is a myth. Weight is not a behavior. Please do not forget this. You can never have a weight goal associated with a behavioral intervention. If you set a weight goal associated with a behavioral intervention, you will fail because you cannot control that weight. Think about it. If I work twice as hard, I should get twice the outcome. You'll never be able to say, if you cut your calories by X, you will lose Y number of pounds, because weight is not a behavior. It is not under behavioral control. So we have to shift that. That narrative then means that, and when we live in an individual control focused culture, so in North America and many of the continents of the planet, not all, we kind of believe in individualism. If you want something, work hard. Don't we tell our children, work really hard and good things will happen to you? So this gives you this fundamental sense of control. And this is where bias comes from. If you don't get the outcome you want, you're just not working hard enough. You're lazy. You just don't care. So we have this kind of individual base. This is a fascinating sort of cultural norm, because in some ways we would say, no, we should be kind of encouraging our kids to have that they have control over the world. But it's that belief in control that's gone a bit too far, which is why if we consider that weight is not under behavioral control and obesity is a chronic medical condition, then all of a sudden the goals and the evaluations shift from the individual to what we would know about any other chronic medical condition, which is there are medical therapies that are needed. And that's why hopefully 20 years from now, then there will be 17 different classes of medical therapies to manage obesity. Just like if you go back in the history of type 2 diabetes or hypertension, there wasn't always these medications. So I hope that's addressed your question.
Right, Michael, and if I get it correctly, and that doesn't, it's not that medical treatments or surgery replaces all the behavioral interventions that you've talked about. In fact, they're actually very complementary, and people should be doing both. I mean, in the same way that someone who has diabetes obviously also needs to be working on their activity and working on their diets and working on their mental health and all of that. So
and if I could just,
the other.
Yeah, if I could just sort of make the point, that's really what we tried to do in our revised guidelines. So we promote obesity management is really this relationship between patients and provider in which they're trying to promote the best lifestyle for the patient, which includes behavioral, psychological, medical, and surgical as the pillars that hold up that relationship approach, where the clinician then is empowered to work with the patient to understand them in the context of their own unique circumstance to come up with a treatment plan. Remember, people that have other chronic conditions, they get diagnosed with another disease, they've never tried to solve that disease before they're diagnosed. But you will not see a patient who doesn't come into you living with obesity who hasn't said to you, I have tried 75 different treatments before. Right. So you shouldn't be saying, here's where we start. You should be recognizing, okay, what have you tried? Where, and now how do we work this together, looking at the pillars that hold up what we believe obesity management is, which is really chronic disease management.
Right. So Michael, Thanks for making that point, because I think it's really crucial to our understanding. We're going to open the floor now, and so I'm looking at you, Sandra. What do we have there? I can see hands going up.
Yes, yeah. So the floor is now open for questions. We will prioritize live questions versus the ones in the chat box. We encourage you to turn on your camera when you're ready to ask your question, introduce yourself, and let us know where you're tuning in from. So you can raise your hand virtually, or you can just raise your hand the old-fashioned way, or simply type in the chat box that you have a question. So let me see here. Does anyone have their, yes, Jamie, go ahead. Unmute yourself, Jamie.
Hello. As a matter of fact, my name is Jaime González Paredes. I'm from Chile, and I'm very glad that I have this opportunity to talk with you for the first time in my life. So I have a really question about the management of obesity. It is, we know that the diagnosis of obesity as a disease depends on many times from the BMI. So we make the diagnosis of obesity disease by the BMI, and then we treat the patient for 3 months, and we discover that that medication is sure and efficient, and for 6 months, and then we, with a number of percentage of body mass index or the weight, we discovered that that treatment was successful. But what happens, please let me know, when the patient isn't able to be diagnosed by the BMI, but by the percentage of, by the body composition with the this argument of the fat mass. We have, for instance, I have many patients that that couldn't be discovered or named as obese people because they had, for instance, 28 or 29 from BMI, but a number of percentage of body fat mass from, I mean, 35, 36 people with over 40. So I start a treatment, for instance, with Saxenda, and then after 3 months, after 4 months, or after 6 months, what is the number that I could, which, for instance, with the Dixa, consider as a successful treatment?
Henry, thank you so much for that question. And I'm going to give this question straight to Ali. And because as you probably might know that in the Canadian clinical practice guidelines, we are actually moving away from body mass index as the definition of the diagnostic criteria for obesity. But we're also in the guidelines making a clear departure from taking weight loss as the main outcome. So, you know, weight management, I think I got this from Ali, is less about weight loss. It should be more about health gain. And I'd like Ali to comment on this. So how do we decide who has obesity, who needs treatment, and how do we measure the success of that treatment?
You know, Jaime, I think the challenge here is that, you know, we all, I don't know if everyone knows the history of BMI. You know, it's the medical index, excuse my French, but it was established in the 1800s by an astrologer who just wanted to look at mass on the planet, adopted by Metropolitan Life Insurance Company, and then sort of snuck its way into medicine through Ansel Keys, who, as many of you know, was not the greatest researcher in the world and probably the biggest fat shamer ever listed. The challenge with it is it's the king is dead, long live the king. And when we think of BMI, it really is the emperor has no clothes. The decision for BMI was we could use calipers, BMI, or water displacement. And they chose BMI because it was just the easiest to do. And so we still use it. And I would argue that you can have patients with a BMI of 35 who are perfectly healthy, and you can have patients with a BMI of 24 who are perfectly not. And, you know, if I had my say, I would argue and this is where we as a medical community have a problem, because we are, make no mistake, obesity is a disease, but we are diagnosing everyone just based on size, and that's wrong. And so we, on the one hand, have medicalized obesity appropriately, but unfortunately we're over-diagnosing everybody. And so, you know, so I think that's part of the problem. The challenge is that without BMI, what do you use? And that's where the nuance of medicine really does come in. So I think, number one, to answer your question, health is a conversation. Now, I'd love to say that every clinician has the time to have that conversation, but we don't. So what I think, you know, that's part of your challenge. What we do here in our clinic is, you know, we know, so if you're going to just stick with numbers, because here's the problem. And even we did this in the guidelines, which is really unfortunate. And it's not our fault. We said, don't use the BMI. But by the way, do height and weight on everybody, which is essentially don't use the BMI, but use the BMI. Shh, don't tell anyone. Right. So that's the problem. We don't have a better test yet. Yeah. The issue here is I think I use it as a ticket, right? So it's a ticket to ride. So yes, check, you can come see me. But the issue is then the problem becomes, what is the health of the patient? And that's where scores like Edmonton Obesity Scale, where you look at sort of other factors that might be influencing health, metabolic indices, mechanical. The challenge with the mental aspect of it is that because you and I live in a society that tells me that Kate Moss is the definition of health and beauty, heroin chic literally is the term, that everybody who doesn't look like that is going to be considered sick. And we have these weird puritanical, sort of moralistic, quite frankly, racist measurements to that. So to answer your question, it involves a conversation that looks at how this person feels. Now, I would say that can happen in 5 pounds, that can happen in 0 pounds, but just with symptomatic relief. So you brought up Saxenda. I talk with patients about symptoms and effect. So symptoms meaning, do you feel more control over your food? Are you less hungry? Do you feel that you can walk into a party and not feel like, oh my God, I'm screwed? And effect meaning, are you seeing any movement on the scale, even weight maintenance? So many of these patients were gaining weight and now they're not. And so I look at those kinds of things. I guess what I'm trying to say to you in an answer is that it's a very gray area because we do not have a black and white, true scientific way of measuring it.
Right, Ali, but we don't have that scientific way of measuring things like depression and other things where we actually talk to the patient, where we talk to...
To some extent, we have PHQ-9s and we have quality of life scores, and we have other things.
Which is basically, you're still asking the questions, you're having that conversation, right? It's a medical diagnosis. It's not something, I can't do a blood test or an imaging test to diagnose those, depression. So it's not unique to obesity. But I think one of the problems we have, and this is that we are stuck with body mass index because unfortunately, when you review the literature on obesity, all the studies have been done,
perpetuating the myth. Absolutely.
Perpetuating that stuff. So we're kind of stuck there. If you want to really look at the evidence, you are kind of stuck with the body mass index. And I think that's going to change over time. But right now, that's why you still see mention the body mass index in the guidelines.
So can I just make a comment about that? Just to kind of wrap it up, because I think that's actually really important. So just to try to encourage the audience, when we wrote the guidelines, we weren't just looking at the guidelines as a typical guideline, which is you find what the evidence is and you tell people what to do based on the evidence. We actually wrote the guidelines hoping that what we could do is not only summarize evidence, but encourage the future directions. So Yemi, the issue you're raising here is absolutely critical. We need other measures. We need measures that are more functional, more related to health. And any of the people in the audience who are researchers, this is, if you got PhD students, we totally need the replacement to the BMI as a way of moving forward. So we completely recognize that kind of inconsistency. We're downplaying the BMI, and yet all the evidence is BMI based. Well, that's because we are actually in transition. So let's just embrace the ambivalence that creates in us all. And the fact is that however we get in front of an individual, what we need to do is identify their health, their functional abilities, and their quality of life indicators, and then engage them in a strategy that we can improve those outcomes.
Right, Michael, and you've used the word transition, and unfortunately this transition is going to take some time because it's not just about us changing the guidelines or the diagnosis, but we're also going to have to look at the regulators who, when they, when a pharmaceutical company comes to them with a drug, what they are interested in, okay, do people lose weight and how much weight do they lose and what's the change in the BMI? And that then becomes the indication for the use of that drug, which comes back to Amy's question when you're asking, well, what's the indication for even using this drug? Am I even allowed to use the drug on someone who does not meet the BMI criteria for obesity? And that comes back to the regulation, and the regulation, before you even have the regulation, you've got the drug companies designing studies, looking at their primary outcome, and that continues to be changed in BMI and weight loss. So so it's not an easy transition to make, but I think we've started the way, and I think that's where we're going to go. So back to you, Sandra, what do we have?
We have a question from the chat box, so Rachel will read that for us now.
The question is from Shiva. Would you prescribe Contrave or GLP-1 to a patient that is in healthy weight, but plus on the sugar, chocolate cravings that affect his lipid profile?
Right. So we're back to our indication question. And so, Ali, quick answer, almost yes or no.
So I would explain to the patient that sugar doesn't necessarily affect their lipid profile, right? So depending on what you're talking about, like if they had an LDL of 7, that's not what they're eating. That's their genetics. I would probably prescribe them a statin first, absolutely. So I think I'd look at their lipid profile first and foremost and address that specifically. You know, I tend to sort of treat, if you have dyslipidemia and a family history, then I'm going to treat the dyslipidemia. That's one. I worry about this idea of prescribing, for example, Contrave for just someone who has cravings, because now we've said that cravings are bad, but they're not. You know, I would have a conversation about this idea of what are the cravings? I think it involves more of a discussion. Does this patient, for example, have true binge eating disorder, which is a completely different ball game and involves a completely different host of treatments? So I think I would tend to, again, this idea of, you know, we're quick to do, oh, I eat sugar. Well, who does? Like, I don't know. I've never met a bun I don't like. Like, I think the idea here of avoiding that sort of puritanical black and white binary good bad is really important, and that's where huge biases come in. So to answer your question, have the conversation, make the proper diagnosis, and then treat this specific metabolic abnormality in front of you.
Okay, all right, thank you for that. So back to Sandra, what do you got?
Yes, Stephen, I'm going to ask you to unmute yourself and introduce yourself and ask your question.
Hello everyone, my name is Stephen, a family doctor from Malaysia. My question is to Michael. So from what I experienced, I think, although it's mentioned the 3 pillars, but for me, I think it looks like a arrow. because at the end, if we prescribe medication without proper behavior therapy or cognitive behavior therapy, or we ask patient to go on surgery without giving the psychological or behavior therapy, I think they will have the rebound. So as a professor emeritus, and I'm sure you have done a lot of study, is there any intention to find out which one is the most superior to start first? It's important because in primary care, we have limitation of time.
Okay,
right.
So
that's a great,
Stephen, thanks
great
for that
question.
Yeah, Michael, if I can add to that question. So what Stephen, I think, is really asking something that we've talked about in the guidelines is how long do you wait for behavioral measures to show success before you actually start having discussions about other things? And the analogy I would like to use, or the question I would like to ask, is when you have a patient presenting with type 2 diabetes, you know, and their blood sugar levels or their A1Cs is 12, how long are you going to wait for lifestyle to work in that patient before you put that patient on metformin? How do you approach this? So do we really have to sequence these things, or can we start them all at the same time?
I think it's a great question. I love it. And so I'm going to answer it in a couple of ways. One, I think, is important to recognize. We did this in psychotherapy in the 80s. So when I just got my PhD, I worked with Aaron Beck in the cognitive therapy group, and we were doing cognitive therapy for depression. And during this time, we were testing what's better, cognitive therapy or interpersonal psychotherapy or Gestalt therapy or psychodynamic therapy. And it was a complete waste of time. And it was ended by a seminal paper that quoted Alice in Wonderland, and the paper was titled "All Have Won and All Must Have Prizes," because it turned out that the magic wasn't in the therapy, it was in the person's ability to adhere to the therapy. We're now in the diet wars, and we're finding exactly the same thing. One diet isn't better than the other. The diet that works is the diet that the patient takes. So we look at medical therapies, behavioral therapies, and surgery together. Any chronic disease management approach requires behavior. So chronic disease, in my mind, it allows us to ask the question, how do the outcomes we're trying to achieve become occurred? And put them in 2 camps. One, the outcomes are achieved by what you do inside the clinical visit. Think of the surgeon, the anesthesiologist. This is where you're the expert and you're in charge. Or the outcomes come not from what the clinician does inside the visit, but from the behavioral choices that the patient makes when they leave the clinic and go back into their world. And these ones you are not in charge of, you are just a collaborator. And this is really where chronic disease lives, including obesity. And so that's why psychological behavioral aspects are actually essential, because it's the patient, the individual, who does the work. So then the question becomes, do they know what to do? Are they supported in doing it? And are they ready to do it? So here's the end of the question answer, Stephen. There's an input and an output. Here is the input. You make a recommendation to your patient because you are an expert. And so you will take from your expertise, if you're a physio, a kinesiologist, a dietitian, a pharmacist, a physician, a psychologist, we all have our competencies, and we will use those competencies to help our patients. So the input is we make a recommendation. Now here is the success. When you make the recommendation, is the patient interested in doing it? Second, when they do it, do they like it? And third, when they do it, do they want to do it again? Doesn't matter what it is. Are you able, here's some idea. Oh, that's great. Thank you, doctor. Oh, really? I was hoping you would say, you're asking me to keep a diary. I hate diaries. That was a punishment when I was in school that I had to kind of do that. I hate diaries. So do you like it when you do it? Are you glad you did? And do you want to do it again? Output. We get our patients engaged in a pathway to change. What is the right pathway? And the output is indexed by 3 steps. Step number 1, can they adhere to it? If they can't adhere to it, then we have to change the plan so they can find something they can be successful at. You've got to be on the ketogenic diet, but I can only stay on a ketogenic diet from Monday to Friday. I can't keep in the ketogenic diet during the weekend. What's the reason? I have a life. I have kids. I have a partner. So do you fail the diet, or is the diet failing you? From an adherence point of view, we would say we're not providing the right treatment to the patient because the patient can't do it. So don't ask someone to do something they can't do. Right. So adherence followed by self-efficacy, confidence to overcome barriers, and intrinsic motivation. And that will be both the input and the output.
Right. So Michael, so I like how you said that, and I think I've said this before. I said, treatments don't, patients don't fail treatments. Treatments fail patients, and that's essentially what you said. And so back to Stephen's question, it's not a question of, when do I use pharmacotherapy, etc. You have to pick the treatment that you think is going to be most appropriate for that patient in terms of, does the patient want it? Is the patient going to do it? And is it going to lead to the result, hopefully, that you want? But a lot of that is going to depend on the patient. So I think we have time for one last quick question. So short question, short answer.
Okay, I think we have one queued up in the chat box then. Rachel?
We certainly do. So the question is from Francis. Do artificial sugars physically give the same positive feedback as sugar to the limbic system?
All right, quick answer, Ali. Yes or no?
So just so we're clear, it's the mesolimbic system. Do not confuse that with the limbic system, which the limbic system is sort of more in keeping with your hypothalamic sort of area. But the answer is no. You need something that's going to boost dopamine, and artificial sweeteners do not boost dopamine. So that's your kind of quick answer to that. Although it might be a bit of top down in that the taste kind of hit and behavioral experience is still there. Biologically, it doesn't create the exact same kind of physiological experience in the brain. The one last, if I could just go back to even add to Michael's point, I think the idea here of culture eating strategy for breakfast even, and I don't want us all to walk away thinking every single patient we see now needs CBT, because then what we do is we take obesity away from primary care and give it only to multidisciplinary clinics that have 50,000 people able to do this. And that then I worry we sort of bastardize the treatment and say obesity is a behavior. And that's what we've been doing before. We said, unless you had a dietitian and 4 nurses, you couldn't practice obesity because everybody needs dietary counseling. The idea here is every patient is different. And should we start cognitive behavioral therapy for everyone? No, we should start it for those who it's most appropriate. And to add to Michael's point, not only do these treatments have to be sustainable, they have to be effective. So I have patients who fail nutritional therapy, fail pharmacotherapy, and fail bariatric surgery, not for any other reason than their physiology. Like, remember, the treatments we're using are this big, and the disease right now is this big. And I would argue obesity is probably 75, 100 different diseases under one umbrella, kind of like we're where we were with cancer in the early 1900s. We probably have 2 chemotherapies for 50,000 different types of cancer. You don't treat lymphoma the same way you treat prostate cancer, but we're treating all obesity the same right now. And I would argue that's part of the challenge of why, and then when patients don't do well, we blame them because it's their fault because they're lying.
Right, so Ali, so I really like that analogy, and and we've used this before. We've said, maybe we should be talking of obesities rather than obesity.
Right.
So I'd like to bring this to the end because we're running out of time here. I'd like to thank both of you for taking the time out of your office. I know, Ali, you have to run off and see patients right away. This is the last one in this, what I call the season, in this episode. We will be restarting the series in a couple of weeks. I think the next one is probably going to be January or so. We'll keep you informed. So if you've signed up for the Obesity Canada website and newsletter, you will definitely find out when this series continues. So on behalf of Obesity Canada, I would like to thank both of you, Ali, Michael, for taking the time. I'd like to thank the audience for attending. I would also like to thank BAUSCH Health for supporting this event. Our focus partners are really important in helping Obesity Canada do this kind of work. If you have not yet signed up for Obesity Canada, go to the website, sign up. If you can make a little donation, make it, because it's a charity. You'll get a tax receipt for doing that. You can follow Obesity Canada on social media. And if you want to continue this conversation, we have the online platform Obesity Connect Pro. Again, you'll find the link on Obesity Canada's website. You can go there. There's already over 1,000, actually well over 1,000 health professionals who are on Connect Pro. And so you can join the discussion there. If you have questions, type them in there. I'm sure you'll have somebody answering them, and there'll be some very lively discussions happening there. So once again, thanks everybody for joining, and back to you, Sam.
Yes, before we close today's session, I invite you to consider what you'll do differently tomorrow morning in your practice. Will you consider that obesity is not a behavior, that it is physiological firings happening, integrating our environment into our physiology, and that weight is not under behavioral change control? Will you consider that eating behaviors are unlike any other behavior, and there are 2 primary pathways: the wanting, which drives us to eat, and the liking, which is the reward and learning that is happening? And lastly, will you understand that your patients struggle between what they should do versus what they want to do? And emotional eating really isn't all eating emotional. And so maybe one step in your treatment plan is to understand your patient's relationship with food and encourage your patients to like what they're eating, and that the food they're eating is liking them as well. So again, I ask you, what is your biggest takeaway from today's session? You will receive a feedback form later on today via email. Please take a few moments to let us know how to best serve you in the next set of series. And remember to type in your full name in the chat box if you would like to receive the certificate of attendance. And this concludes our Get Real Spotlight series. We hope you have found these sessions to be engaging and insightful. We're working to bring this back in early 2021 and look forward to seeing you again. Bye for now.
Thank you, everybody.